Results of a phase 3 trial adding temozolomide to short-course radiotherapy in elderly patients with glioblastoma, the most common form of brain cancer in adults. Please join me in welcoming lead author Dr. James Perry, the Crolla Family Endowed Chair in Brain Tumor Research at the Odette Cancer Center and Sunnybrook Health Sciences Center in Toronto.
Good morning. Thank you, Dr. Vose. It's indeed a pleasure and an honor to be invited by ASCO to present today, and I present on behalf of the co-principal investigator, Dr. Norm Laperriere, who's in the audience, and the leaders from various academic cooperative groups around the world. This study was also led by the Canadian Cancer Trials Group, so it's a great day for this group, and in close collaboration with our colleagues, longstanding colleagues at the EORTC, the Trans-Tasman Radiation Oncology Group, and Japanese investigators. So as you just heard, glioblastoma is the most common primary brain cancer. It's one of the most common causes of cancer death and the lead cause of cancer death in patients between the ages of 40 and 60. Important for this study is the fact that the peak age of incidence of glioblastoma is 64 years, and the incidence appears to be increasing with our aging population. Current best practice for this disease is surgical resection, followed by radiotherapy, combined with chemotherapy. And this is a chemotherapy called temozolomide, which is an oral capsule form of chemotherapy. And there was a pivotal trial presented a little over 10 years ago here at this meeting, and also at a plenary session. But that pivotal trial was restricted to patients under the age of 70. Very few people over the age of 65 were included. And in subgroup analyses of that study, there was decreasing benefit for the addition of temozolomide with increasing age. So the studies that we have in older patients over 65 have only compared radiation schedules head-to-head and radiation alone versus temozolomide alone. There's never been a trial of combined chemotherapy with radiation in elderly patients. And oncologists up till now, therefore, have only had evidence-based choices using radiation alone or chemotherapy alone, but not combined modality therapy. Next slide, please. So the study design was quite simple. These were newly diagnosed patients over 65 who gave informed consent, and they were randomized 1-to-1, so 50-50, to radiation alone. And this consisted of the 40 gray and 15 fraction 3-week schedule. So we call this short course radiotherapy, hypofractionated radiation therapy. And they were randomized to radiation alone or the same radiation plus temozolomide chemotherapy on the days of radiation and weekends in between, followed by up to 12 monthly cycles of adjuvant temozolomide. And they were followed for quality of life, progression-free, and overall survival. And we enrolled 562 patients in a global cooperative group academic trial. Next slide, please. These are the results. In the top right, overall survival. So overall intent to treat populations showed that survival was improved for all patients in the study with a hazard ratio of 0.67. Progression-free survival was even more significantly improved, and I didn't show that slide here. We know that in this disease there is a biomarker called MGMT promoter methylation that predicts response to chemotherapy, is a prognostic factor for survival, and is a predictive marker of benefit from temozolomide. So we collected this, and not surprisingly, patients that harbored a methylated MGMT promoter, that's in the bottom left slide, had substantially more benefit than the patients overall, with a hazard ratio of 0.5, resulting in an extension of median overall survival from 7.7 to 13.5 months. A little bit to our surprise, patients who harbored unmethylated MGMT promoter also appeared to derive clinical benefit from this therapy with a hazard ratio of 0.75, which was actually the hazard ratio that we were looking for in the study overall. Next slide, please. The advantage of this combined treatment with chemoradiation was achieved with minimal side effects. Our quality of life scales have shown increases in nausea and vomiting during the first 1 week of radiation and temozolomide, a slight increase in grade 3 and grade 4 hematological toxicity, but less than 5% and a bit less than we were actually expecting to see. And no differences in quality of life measured by standardized validated quality of life measures, such as the EORTC QLQ-C30 and the brain-specific module. Thunderous response. Patients were able to complete the treatment plan easily, and this was quite important because the elderly often have difficulties with mobility, distance from treatment centers, and sometimes don't have caregivers that are able to bring them back and forth for treatment. And the shorter radiation schedule is undoubtedly an advantage in this regard. Next slide, please. So in conclusion, a shorter course of radiation therapy with concurrent and adjuvant temozolomide significantly improves progression-free and overall survival compared to radiation alone in newly diagnosed patients, newly diagnosed elderly patients with glioblastoma. The benefit was seen mostly in patients that harbor MGMT promoter methylation, which is a test that's done on the brain tumor tissue removed at the time of diagnosis. Clinical benefit, perhaps a bit surprisingly, was also found in patients with unmethylated tumors, but it was less robust than in patients who had the methylated MGMT promoter. This survival advantage was gained without a sacrifice in quality of life and with the expected and manageable treatment toxicities that we've come to know with temozolomide chemotherapy. And oncologists now have evidence to consider radiation with chemotherapy in all newly diagnosed elderly patients with GBM. Thanks for your attention.
Thank you, Dr. Perry. I think this is a really important study in a number of ways. One is that we're testing a very important question worldwide, and we're testing it in the population that actually gets the disease, in the older population. So very important to make sure that our clinical trials are extending to the patient population that could most benefit from that. And we really appreciate the Canadian Clinical Trials Group for coordinating both of those trials.